Good evening, everyone. My name is Dr. Noman Memon, and I'm here at Gaziosmanpaşa Hastane Hospital, Istanbul, for my fellowship in wrist arthroscopy and microsurgery. Today, I'm going to present a topic of Kienböck disease. So Kienböck disease is an isolated disorder of lunate resulting from vascular compromise to the bone, avascular necrosis, osteomalacia of the lunate. Dr. Robert Kienböck described this disease in 1910. He described a stepwise progression disease from isolated proximal lunate involvement to fragmentation and collapse of lunate, evolving to radiocarpal involvement with degenerative changes. What is the etiology of the Kienböck disease? The exact etiology is unknown, but it is likely multifactorial. The number one factor is anatomical factor, and the second is interrupted vascularity, and the third is the traumatic insult to lunate or repeated microtrauma. So what are the factors that include in anatomical variations? Number one is the ulnar negative variance. Three types of lunate morphologies. Type 1 lunate has proximal apex, type 2 and type 3 more rectangular. So type 1 seen in wrist with negative ulnar variance and has a higher rate of developing Kienböck disease. Third factor is a low radial inclination. All these anatomical factors seems to be results in unequal load distribution through the radiocarpal joint. So the main idea behind all these factors is the main idea is the unequal load distribution through the radiocarpal joint. Either it is a negative ulnar variance, or it is a low radial inclination, or there is a morphological change in the shape of the lunate. All leads to unequal load distribution. So the second factor is the interrupted vascularity. As we all know, the vascularity to lunate is variable. There are three major patterns of vascularity described into the textbook. The number one is a Y pattern, number two is an I pattern, and number three is an X pattern. In I pattern, there is a single vessel supplying the lunate, which may increase the risk of osteonecrosis. But it can happen with all the other varieties, but most commonly seen in the I type variety of the vascularity. So this is an illustration. You can see I, X, and Y type. In addition, avascular necrosis of the lunate has been linked to vascular insult caused by fracture, ligamentous collapse, primary circulatory collapse, systemic disease, and venous congestions. Although there is no single definitive cause of Kienböck disease, a complex interplay of vascular and anatomic variations combined with varying degrees of microtrauma and insults contributes to its development. The clinical presentation commonly affect men's 20 to 40 years. Symptoms can vary depending upon the stage and initial presentation. Pain localized to the radiolunate facet pain is classically insidious in onset, decreased wrist motion with time, and swelling and decreased grip strength. Tenderness over the dorsal lunate and radiolunate facet. An effusion or bogginess overlying the radiocarpal joint can be appreciated. Movements, especially dorsiflexion, is limited. And this is an alarming sign as well. Average grip strength may decrease up to 50% of the contralateral side. In extreme cases, clenching of hand fails to show the normal prominence of third metacarpal. That is also known as Pfister's sign. Percussion over the overhead of third metacarpal may elicit tenderness. Radiographic imaging, X-ray of the wrist, PA, and lateral views, negative in early stages of the disease process, progressively shows increased lunate density. In the early stages, you should confirm your clinical diagnosis with the help of an MR scan. Progressively show that is very much necessary because the disease is very much necessary to diagnose in early stages. Otherwise, you cannot salvage the lunate in the later stages of the disease. Progressively shows increased lunate density. In the later radiographs, you can see the fragmentation, collapse, proximal migration of the capitate, widening of the proximal carpal row, scaphoid rotation, and degenerative changes in the radiocarpal bone. So this is an MRI. As you can appreciate, there is an avascular necrosis of the lunate. So MR scan can detect early stages of disease with increased signal uptake. In patients with perilunate dislocations or ulnar impaction syndrome, changes within the lunate may appear similar to the AVN. However, these changes are often focal and non-progressive. CT scan characterize the lunate necrosis and trabecular destruction once collapse has occurred. And CT scan is also important in understanding the deformity before any surgical intervention. You should go for a CT scan for your preoperative planning and for the correct correction of your deformity. Staging, Lichman described the radiographic classification of the disease. It is divided into several stages. Stage 1, in which you will see the normal radiograph, but you should evaluate further with the help of an MRI. And in stage 1, you may show possible lunate fracture, but most of the time in stage 1, the radiograph looks normal. In stage 2, there is some sclerosis of lunate, but there is no collapse. And in stage 3A, lunate is collapsed, no scaphoid rotation. In stage 3A, the lunate is collapsed, but the scaphoid is not mal-rotated or mal-aligned, and surrounding bones may shift, but the scaphoid is in the normal position. And in the stage 3B, the lunate is collapsed along with the scaphoid rotation. And in stage 4, obviously, there are degenerative changes around the lunate, and the wrist may become arthritic. So we will go through with the stage-wise pattern. The stage 1 is non-specific intermittent wrist pain and synovitis, which may mimic a wrist sprain. Plain X-ray films are either normal or show a small linear compression fracture through lunate. There is no collapse, sclerosis, or increased radio density of the lunate. But MRI shows a decreased signal uptake in stage 1. Stage 2 characterized by increased swelling, varying degrees of stiffness and progressive pain. X-ray shows lunate sclerosis with or without compression fracture lines. But there is no evidence of the collapse. Lunate height is maintained in stage 2 disease. The remainder of the corpus remains without degenerative changes. This is also a radiographic illustration of the stage 2, in which you can appreciate the sclerosis, but the height of the lunate is intact. In stage 3A is defined by continued sclerosis and collapse of the lunate, but there is no rotation of the scaphoid. Carpal height and intercarpal alignment is preserved, no scaphoid rotation. X-ray lunate appears whitened in AP view as a result of the coronal plane collapse. Scapholunate angle is preserved at -10 to 10 degree. In stage 3B, as we have already discussed, that there is a sclerosis collapse and there is a rotation of the scaphoid, and most of the time rotates, resulting in Desai pattern of instability. As you can see in this picture, that there is a collapse and along with the rotation of the scaphoid. Stage 4 is the progressive carpal collapse leading to radiocarpal and midcarpal regenerative changes. X-ray joint space narrowing, and subchondral sclerosis, degenerative cyst, and osteophyte formation. Symptoms have typically progressed to stiffness, constant pain, and swelling. So there is arthritis in the wrist. So what about the treatment? The treatment is based on the stage at presentation, and the aim of the treatment is to unload the lunate. And the basic treatment is to unload the lunate, revascularize the lunate, and treat carpal instability and collapse with salvage procedures. These are the three main aims of the operations, and the treatment option will be based on the stage at presentation. In stage 1, you can go with the conservative treatment with 3 months immobilization is typically recommended for stage 1 diseases. The patient should continue to be monitored, and if symptoms or radiograph progress, consider surgical options for stage 1. For stage 2 or 3 with negative ulnar variance. In this, the ulnar variance is negative. So the goal in this stage is generally centered towards ulnodding of lunate in an attempt to reduce the intercarpal stress and allow revascularization. So we do joint leveling procedures in stage 2 or 3 with negative ulnar variance. So in joint leveling procedures, we can go for radial shortening osteotomies. We can go for ulnar lengthening procedures. Radial osteotomy is preferred over ulna due to the less complications. So these are known as joint leveling procedures. In stage 2 and 3A with ulna neutral or positive variance. So in this case, what we can do is we have to revascularization and osteotomies and core decompressions. These are the procedures we can offer in positive variance or neutral variance of the ulna. So how can we do revascularization? So the principle is transplantation of an arteriovenous pedicle into a normal and avascular bone results in new bone formation. This is a principle of revascularization. Direct revascularization allows the potential for salvage of the lunate and possible reversal of destruction of lunate through new angiogenesis. So what are the sources of revascularization? The sources of revascularization includes distal radius pedicle graft with pronator teres and vascularized pisiform graft, 4th and 5th extensor compartment artery graft, 1st, 2nd, or 3rd dorsal metacarpal artery transfer. These are the different options for revascularization. As far as the osteotomies are concerned, goal of this procedure is to unload the lunate in an attempt to decrease stress across radiolunate joint to allow revascularization and prevention of disease progression. Capitate shortening osteotomies with or without capitohemate fusion. Radial closed wedge osteotomy will shift the pressure from lunate by decreasing radio-ulnar inclination. These are the summarized goals of the osteotomy. In this picture, as you can appreciate, there is a radial shortening osteotomy. Core decompression. Metaphyseal decompression of radius and ulna. Decompression involves curettage of distal radius, ulna through small cortical windows. Healing is due to local vascular response. So this is the main idea of core decompression. In stage 3B, obviously, there is a rotation of the scaphoid as well. So the goal in this stage is stabilization of the carpus, prevent further collapse, and decrease the load across radiolunate joint. Scaphoid, trapezoid, trapezio-trapezoid arthrodesis. These are the options: proximal row carpectomy, STT arthrodesis, scaphocapitate arthrodesis, grafting, arthroplasty, and interposition. All are the options that have been given into the textbook. Proximal, but what we prefer proximal row carpectomy. This is a good operation and with a very good functional results post-operatively. In proximal row carpectomy is procedure that excises the scaphoid, lunate, and triquetrum, transferring load from the capitate directly to the lunate facet of the distal radius. I will show you one case in this. As you can appreciate in this X-ray, there is some sclerosis of the lunate on the AP view, and on the lateral view, you can appreciate there is some collapse of the lunate, which is very much visible. And we offered an MRI, and on MRI, as you can see, that the lunate has undergone into avascular necrosis. And on the lateral side, you can see that the height of the lunate is also collapsed on the MRI. And we offered a CT. So in CT, you can also appreciate a fracture line into the lunate, which is visible on both the slices of the CT. So we decided to go for a proximal row carpectomy, which is an arthroscopy assisted procedure we do here routinely into the in Gaziosmanpaşa hospital. So this is a video of the patient. These are the arthroscopic views of the proximal row carpectomy, and you can appreciate that we did the proximal row carpectomy. Most of the ulnar side we removed through arthroscopy with the help of the burr and curettes and clamps. And we do open mini open onto the radial side for the removal of the scaphoid. So this is a mini incision over the radial side, and most of the dorsal capsule is intact for the stability of the remaining carpal bones. So you can see that we have removed all of the carpal bones into fragments with the help of arthroscopy, and some of the scaphoid with the mini incision. These are the per-op C-arm pictures. All of the proximal row has gone. And these are the post-operative X-ray. As you can appreciate in this, the scaputate is directly coming to the lunate fossa for further articulation. These are the other options, obviously written into the book. This is the STT and ST arthrodesis. And some controversial topic is lunate excision and silicone lunate prosthetic replacement. But I have no experience about this kind of procedures. And in stage 4, this is the salvage procedures performed. In stage 4 as well, if the degeneration is very mild, you can go for a proximal row carpectomy. And if it is very high grade, so you will go for a wrist arthrodesis or a wrist arthroplasty and this wrist denervation. Thank you for listening me, and I would like to thank Dr. Bulling and Dr. Barkan Marsa for allowing me to present this topic on their forum, and helped me a lot through my presentation and my cases. Thank you to both of my bosses once again. Thank you very much. Thank you very much for listening.